Good morning, everybody. Welcome to week 2. It goes very quickly. Okay, so here's what we're going to be talking about today. We're going to talk about some prenatal education. We're going to talk about how we help our pregnant clients achieve a healthy pregnancy. And we are also going to talk a little bit about some complications of pregnancy. I've got a couple case studies we're going to talk about. Really exciting. So let's get started. We don't have very much time, so I like to hit the ground running. So here we go. All right. So GTPAL classification. This trips students up all the time, so I'm going to spend just a little bit of time talking about it. So it's very important that we know when we are caring for pregnant women, how many babies they've had, what was the age of the fetus at delivery, did they have any complications during any of their pregnancies that they've had in the past, how about abortions, have they had those, all those kinds of things. It's very important for us to know that. So we have a classification system that we use. G for gravid, that's just meaning that the woman is pregnant. That's really all that means, just the state of being pregnant. Parity, meaning the number of pregnancies that the woman carried to at least 24 weeks. So the GTPAL is a system, we've expanded it some. It used to just be GP, okay? But we've expanded it some to be a little bit more specific. We need to be as specific as possible. So our gravida, just the number of times that the woman has been pregnant. That's all that means. The T for term, so how many babies has she delivered that were at least 37 weeks up to 40 weeks. 40 weeks is full gestation, okay? P for premature, how many babies did she deliver that were before 37 weeks, okay? A for abortion, that includes spontaneous and elective. If she had the abortion done for some reason, either she chose to have the abortion done or it was something to do with health that she had to have an abortion done, that doesn't make any difference. It's all clumped into one category. Living, this is where the number of children comes into play, okay? This is the only category where the number of children come into play. It gets very confusing when we're talking about a multiple gestation pregnancy. In other words, more than one baby. Oftentimes, your twin pregnancies, triplets, quadruplets, all of that, quintuplets, a lot of times those babies are not going to be carried to full term. So they're going to fall under the premature category. But the number of babies doesn't enter into the premature category. Only how long the pregnancy went for. That's all that means. So that gets a little bit confusing. So please take some time to review that in your textbook. I think your textbook gives a really great explanation of that. Take some time to practice it if you can. Just make up some numbers, make up some, oh, okay, I'm working with this pregnant lady. She's been pregnant X amount of times, and I know her G would be this. And, just play with it a little bit. Do some practicing because you are going to need to know this, this stuff, okay? Any questions on that from anybody? Feel free to unmute. I have everybody on mute, but if you have a question, feel free to unmute yourself and ask, because I don't always catch the chat.
So just real quick, when you said like if they're premature and they're quadruplets or triplets, that does not count as premature?
It does count as premature. It's the number of babies doesn't count. The only time we talk about number of babies is under the living category. Not any of the others.
Just count as one premature even though it's 4 babies.
You gotcha. You gotcha. Yep, that's right. That is right. Okay. All right. Any other questions? That was a good question. Okay. Moving on to the next confusing category. Nagel's rule. Okay. So this is kind of how we figure out their estimated date of confinement or their estimated date of delivery, whichever way you choose to think of it. It was always estimated date of confinement when I was in my practice. So we take the first day of the last menstrual cycle. So you ask your client, when was your last menstrual period? And they tell you, okay, so when was the first day of that? When did it start? Then you add 7 days to that, and then you subtract 3 months, and then you add a year. So, for example, I have an example up here. If the last menstrual period was in February, this past February, February 10th of 2020, so we take 10 plus 7 is 17. So that would be February, or that would be the 17th. That would be the day of the month. So February is just over the new year, right? So if we're subtracting 3 months, now we're going back to last year, aren't we? So that would be November of 2019. So, and then you add a year, their estimated date of confinement would be November 17th of 2020. Again, I'm going to advocate that you do some practicing with these, play with this a little bit, make up some numbers, talk to your family, your friends, say, okay, just give me some numbers, give me some dates, and just play around with it until you feel comfortable with it. That's the only way you're going to feel comfortable with it, is if you practice with it. Because again, this is content that you're going to need to know. Okay.
Laura, I just wanted to let you know that during the clinical simulation last week, they have Nagel's rule as adding 9 months, not subtracting 3 months.
That's okay. I mean, this is the way that they do it according to the textbook. So I'm just giving you the information according to what the textbook says. But either way, you're going to come up with the same thing.
Okay, right. Yeah.
Yep. Any other questions? Thank you, Belinda. I appreciate that, for you bringing that forward. Okay, so just take some time, practice, take a look at it in the textbook. Just play with it a little bit until you feel comfortable with it, because this can be confusing. So just take some time to practice it. Okay. All right, I'm moving on. Okay, so some very important things that we do throughout our client's pregnancy is antepartum assessments to establish fetal well-being. Very, very, very important. Antepartum meaning before the labor, right? This is before the labor. Okay, so I've got a couple of things up here that I'm just going to go through. One of the tests that we can do is an amniocentesis, and some of you may have heard of that before. This is one of those terms that I was telling you about that would be important for you to know. It's an invasive procedure, so it's not something that is done routinely. It is something that is done if it is necessary. So some reasons that we may need to perform an amniocentesis would be if they need chromosomal testing. Potentially there is a genetic anomaly in the family, or they had a previous pregnancy that there was some genetic anomaly. If the female is of advanced maternal age, they may opt to do some testing like this to check for any genetic anomalies that could be present, because the older the woman is, the more risk there is for genetic anomalies to appear. So they take a very long, terrifying looking needle to draw out some of the amniotic fluid. And this is done under ultrasound guided, right? Because they have to know where the baby is, because there is a risk of puncturing baby with this really long needle. If you've ever seen it, it's terrifying. It's absolutely terrifying. Oh, Claudia says they're awful. You know what? They scared the bejesus out of me, I can tell you that. So performed around 12 to 14 weeks, give or take. So chromosomal anomalies, as I said, they can assess for fetal lung maturity. So, if they're thinking that there may be a risk of a preterm delivery, they may want to assess for fetal lung maturity. They can look for other things. They can tell the sex of the baby. That's obviously not the way that we would want to do it. It's too invasive. But there are some complications that can arise related to an amniocentesis. They can look for signs of infection. Obviously, if they draw out the fluid and it doesn't look right, they would be concerned of infection. But if mom had something we call polyhydramnios, where she has too much fluid, ideally we want there to be between 600 and 800 milliliters of fluid. That's ideal. And think back to when you learned about what homeostasis was. We like to be at a certain range. We shouldn't be above it. We shouldn't be below it. And this is no different. So ideally, 600 to 800 milliliters is what's ideal. So sometimes mom may produce more fluid than what is necessary. And if that occurs, that could potentially lead to complications. The uterus could get overstretched. Remember, it's a muscle, and it could get overstretched, and that could lead to issues during the labor process because we need that muscle to be tense during the contractions. We need it to apply pressure to push the baby out. And if it's overstretched, that can be a problem. That can lead to difficulty with the labor. So they could do an amniocentesis to remove some of that extra fluid. Again, there needs to be a reason for doing the amniocentesis. That's not something that they're just going to jump to because of its invasiveness and the potential for complications. Mom could get an infection, right? Anytime that you're doing anything invasive, there's always risk of infection. And if mom ends up with an infection, baby could end up with an infection. What happens to mom could potentially happen to baby. What affects mom affects baby. So there's risks involved. This is not something where mom would have to be hospitalized, okay? This is an outpatient procedure. She comes in, she gets it done, she recovers, they make sure everything looks okay, she goes home. She basically would just have a Band-Aid over the insertion site, and that's it, okay? All right. The next thing, very simple. This is a non-invasive assessment that mom can do at home that we would teach her how to do, called counts. Okay. So you are counting the number of fetal movements. Very important. This is a good indicator of the fetus's well-being. So the way that we educate would be for them to either be sitting, like maybe in a recliner, or they need to be laying down. And left lateral is ideal. That's where baby's getting the most oxygen, is when mom's on the left lateral side. And she places hands over the abdomen, and she's basically just counting the kicks. Every time she feels a kick, she counts it. And she does this over a 2-hour period. The caveat to this is she needs to be aware of when baby has its sleep cycles, because fetuses have sleep cycles. So when the baby is least active, that's not the time she wants to be doing this. She wants to be doing this type of assessment when the baby is most active, because then it's going to be the most accurate. So that is the caveat to that. If she does it during what she would assume would be a baby's really active period, and she gets less than 10 over that 2-hour period, then she needs to reach out to her provider right away, because this could be an indication of a problem. And we want to jump on it quickly. We need to be proactive about it. That's why we teach them how to do these, so that we can be alerted early and do something early. Check it out. Make sure that there isn't something going on. Okay? All right. Any questions on that? Does that make sense? I mean, it's pretty simple. It's very important that we provide that education, though, that we're making sure that she understands what she needs to be doing when she's at home. Does that make sense for everybody?
Is the 600 to 800 milliliters, is that like during the entire pregnancy?
That is how much ideally we would have, yes. When she delivers, that's how much fluid she would have.
Okay. It just sounds like not enough sometimes.
Oh, yeah, it's actually more than you think. When you think about the space that it's occupying, and with the baby as well, that's actually kind of a lot. Yeah. Any other questions, guys, before we move on to the next part?
What was the level again for the fluid? 600 to 800 milliliters?
Yes.
Okay.
Yep. All right. So another test that we can do is called a non-stress test. This one is frequently done when you have somebody coming into the labor unit that needs to be evaluated for whatever reason the case may be. So there usually is some bed set aside in every labor unit for what we call antepartum, right? Before labor. So these are the types of tests that they do. They do this kind of test. They do contraction stress tests. All of these tests are to assess how baby is going to tolerate the labor process. Okay, so what they do is, as you can see in the example that I have there, they put the external fetal monitor on. One is monitoring baby's heart rate, the other monitors the uterus. They give mom a little button, very similar to what you would have with a PCA. And they have her monitor baby's movement over like a 20-minute period. Every time she feels a movement, she clicks the button. If baby's not moving, there is some little device that they can use to kind of give the baby a little gentle nudge in the uterus to get baby to move. The whole thing is to watch the heart rate. That's the whole thing. We want to see what the heart rate does in relation to those movements. If they have a lot of dips, then that could be potential issue for the labor process. So it is definitely something to be aware of. So they're basically checking to make sure that baby's neurostatus and their heart status is intact. That's very important for us to know because labor is a very difficult process for the baby. It causes a lot of stress on their system just like it does on mom. Okay, so I mean you're going at this for multiple hours. There's multiple contractions that are occurring, lots of pressure being applied to baby. So we need to make sure that baby is going to be able to tolerate that. And this is one of the things that we can do to assess that. Now, again, this is not something that is routinely done on everybody, but if there's indications for it, they definitely would do it. If mom had a previous pregnancy where she had a lot of what we call D cells, and we're going to talk more about those next week when we talk about labor, but if she was having a lot of dips to the baby's heart rate during that labor, then they probably would do something like this for her for subsequent pregnancies, just because if you have it in one pregnancy, there's always a risk that you'll have it in subsequent pregnancies. Okay, does that make sense for everybody? Anybody have any questions over any of those tests? No? All right. Okay, so last assessment that we're going to talk about today, bundle height. Okay, so this is looking at uterine size in relation to the gestational age that we're coming up with. So generally, this doesn't get done until we get into the second trimester because baby needs to have grown, right? I mean, we're not going to be able to really do this during the first trimester. It's too difficult to assess where the fundus is at. The fundus is the top of the uterus. That's just another word for the top of the uterus. So that's one of those terms. Make sure that you know what that is. It's very important. So generally 22 to 34 weeks, that's the time range that we're doing this type of assessment. It's very simple. We find out where the top of the uterus is. We take a measuring tape and we measure from the symphysis pubis up to the top of the fundus. Very simple. Very, very simple. They can use hands to measure. They use like finger breadths. The problem with that, doing it that way, is, first of all, that's very old practice. It's very out of date. It's not considered best evidence anymore. But they used to do it that way. The problem is you would have to have the same care provider doing it each time because of hand size. So it's not going to be accurate if the same care provider is not doing it each time. So that's why we use tape measures, because that's going to be accurate, right? So they should correlate plus or minus a couple of weeks. So the example that I put on here is if you have 28 weeks, then your fundal height should be 28 centimeters. So it should correlate. If you're way off, then it's time to kind of investigate what could be potentially going on. If it's a lot larger than what we would anticipate it to be, then maybe mom has more fluid than we think she has, or maybe baby is larger than we would anticipate. So then we would probably want to do a little bit more investigation into that. If it's a lot less than what we would anticipate, again, we're worried about baby's growth. This is basically looking at baby's growth. It really is. So if it's a lot less than what we would anticipate it to be, then again, we want to take a look, do some more investigating. They might want to do an ultrasound to establish baby size and see where it's at, make sure that we have the right gestational age. You know, with the ultrasounds that they use today, it's very simple to establish gestational age, and they're very, very accurate. So, but in your textbook, figure 9-6 is where they talk about this, the fundal height. So make sure that you review that, because again, this is content that you're going to need to know. Any questions on the fundal height? It's a pretty simple thing to do. It doesn't really take a lot of skill to do it. But again, providing that anticipatory guidance to our clients, telling them why we're doing it and what we're looking at when we are doing it.
I had a question.
Okay, go ahead.
The fundal height, is that something that's palpated, or is that just the curvature where it stops at the abdomen?
You palpate it. You palpate the top
So you
with your
can
hand.
feel that.
Yep,
Okay.
you can. You definitely can.
Okay.
Yep. Good question. Good question. Thank you. Any other questions?
What figure did you say in the book? 9 what?
9-6.
9-6.
Yep. So it's in chapter 9. Any other questions, guys? Okay. Well, we're going to move on to our first case study. Here we go. Now, I like the case studies to be what I call a roundtable discussion. So I want discussion. I don't want anybody typing things in the chat. I want to hear you. I want to hear you guys, okay? So don't be afraid. Please, please, please. All right. So here we go. You are discussing the issue of infant feeding with your 26-year-old pregnant client during a prenatal visit. She's pregnant with her second child. Her first child was formula fed and experienced issues with ear infections and allergies, very common with formula fed babies. The client states, I'd really like to try breastfeeding with this baby, but my mother says I can't because my breasts are too small and I won't make enough milk. So how are you going to respond? Now remember what I said last week. Culture is learned, right? Well, pregnancy is learned. Okay, we get our information from our family members. We get our information from our friends. Okay, so, you know, grandmas share their stories with grandchildren. Moms share their stories with daughters, and the aunts share their stories with their nieces, right? So a lot of times when we are taking care of these pregnant women, they're bringing all of those myths and stories with them. And we have to help them kind of dispel all those myths. So how are you going to respond to this client? What are you going to say to her? This is going to be very important. So what are you going to say to her?
Breast size doesn't make a difference in the amount of breast milk that you produce.
Okay, but remember, her mother told her, so we don't want to disregard what mom says, right? Because that could set our client against us. If they believe everything their mother says, mothers are very influential, right? I mean, we believe what our moms tell us. They're not going to tell us something that isn't right, are they? So we have to make sure that we are being, again, supportive, but we need to make sure that we're giving her the correct information. We don't want to come off as saying, nope, you know what? Your mom is totally wrong. this is what's right. So we have to be careful how we approach it. You're right, Echo. You are right. What you said was right, but it's how we're going to approach it that is important.
Could one approach be to acknowledge her cultural beliefs, but also maybe give advice on like how you could stimulate more milk production if she was worried about it?
Yes. Oh, awesome. Thank you so much. Yes, perfect. Perfect. So, yes, let's talk about, well, I mean, there's pumps that you can use to help. We will be giving you instructions on how baby should latch, making sure that baby latch is good, right? Because the latch is very important. Latch is everything when we're talking breastfeeding. Now, remember, when you're talking breastfeeding, it's not innate. Everybody thinks that it's innate. We just know what to do. That is not true at all. Breastfeeding needs to be taught. So make sure that they are latching properly, that, to prevent risk of infection to mom, because if baby's not latching right, first of all, it's going to be very painful, more painful than you would anticipate it would be. And that can lead to getting an infection inside the breast because of that constant rubbing that the baby is doing with their palate. That's going to abrade the skin of the nipples. So that's going to cause problems. Very good. Excellent. Thank you, Shannon. I appreciate that. That was wonderful. Anybody have any other thoughts?
Could we refer her to the lactation specialist or the lactation nurse and give her some printed material to review at home and even with her mother?
Oh, yeah. Oh, we could. Yes, we definitely could. And one thing we might let's invite grandma to come. How about it? Let's set up a meeting with the lactation consultant and bring everybody in. And let's all learn together. Because remember, this is a family process, right? So the more family members we get involved in that process, the better it's going to be for the pregnancy overall. Because our goal is a healthy pregnancy, right? Our goal is for mom to be healthy. Our goal is for the baby to be healthy. And emotions are key to that. So let's get everybody involved, right? We're not disregarding what grandma says. We are not doing that at all. And we definitely don't want to show any disrespect whatsoever. But let's bring her in and let's talk about it. Let's show her the evidence. Let's show her the science and see where we go from there. Right? Good. Excellent. Good job, guys. Anybody have any other thoughts? You guys are doing great. Okay, I'm not getting any other thoughts. All right, excellent. So this type of situation is going to be something that you potentially might see on your exams, because education is the key to this practice setting, guys. You have to be able to educate your patients and their families. So I would definitely advocate for you, if you're doing practice questions, look for education questions. Do as many of those as you can, because these kind of questions trip you guys up all the time. It's very important that you understand how to educate. There's a right way and a wrong way to say things, right? And in this type of situation that we have right here, culture plays in, and we definitely don't want to be disrespecting their cultural beliefs at all. Okay, we want to make sure that we're embracing them, that we are respecting them, and that we are integrating them in, because nothing is going to turn them off more and affect our therapeutic relationship that we are trying to build than if we just completely disregard what their families are telling them. Because there's a lot of myths involved. My mother had a ton. I'll give you an example. When I was pregnant with my first kid, my oldest son, I am about, 36, 38 weeks. And she says to me, okay, I want you to stand on this chair. This was so ridiculous, guys. But I did it because I wanted to make her happy. Stand on this chair. She found a skeleton key from wherever, I don't know. Wrapped a string around it. She says, okay, stand there and just hold the key. So I'm standing there holding the key, thinking, please don't let me fall off this chair. And she says, if it swings side to side, it's going to be a girl. If it swings back and forth, it's going to be a boy. I thought, what the heck? She believed it. That's all I can say. So, but me, I, I knew better than to argue with my mother. So you probably all got some sort of something that your families have shared with you about your pregnancies. And, you know, if you're carrying up high, it's a girl. If you carry lower, it's a boy. You know, there's all kinds of wives' tales and myths related to pregnancy. So, again, we don't want to disregard any of those. We want to educate. That's all. We just want to educate. Lots and lots of different ones. That was just one that I thought I would share. I did it, you know. Oh yeah, baby showers, right? Don't break the bows. Then you're gonna have however many babies, however many whatever. I don't know. Yeah, there's lots of fun stuff. There's really a lot of fun stuff involved with babies. Okay, so let's shift gears just a little bit. Great job, guys. Thank you so much for going along with it and for giving your input. I do appreciate it. I love it when we interact. It's just the best. Okay, here we go. So let's talk about some danger signs of pregnancy. Okay, these are very important. Again, we want to provide what we call anticipatory guidance. Anticipatory guidance meaning the what ifs, what to expect, right? So during the first trimester, nausea and vomiting could potentially be a danger sign because if it's severe, then she may have electrolyte imbalances. She may end up losing weight. She's not getting the nutrition that she needs. She can get dehydrated. So it can become, you know, if it becomes severe, it can be a sign of danger. Okay, so there is something called hyperemesis gravidarum. I used to take care of these clients all the time when I worked in the adult medical pediatrics environment. So don't think just because you decide to work on a medical unit, you're never going to have to take care of any pregnant women, because that's not going to happen, guys. I can guarantee you that. You will have them. They can be anywhere. They can be in radiology. They can be in the emergency room. They can be in the clinics. They can be anywhere. Okay, and I took care of a lot of pregnant women that were having issues with vomiting. They would come in for fluids, and sometimes they would come in and have PICC lines placed and have to have hyperalimentation done. I mean, you know, it can be significant. So abdominal pain and vaginal bleeding. So this could be an indication of what we call an ectopic pregnancy. Because we're talking first trimester, it's an indication of an ectopic pregnancy, potentially. Okay. So, or it could indicate that she's aborting. So definitely indication of something not right. Infection. If she's showing signs of having an infection, malaise, fever, chills, any of that. Burning on urination, she could potentially have a UTI. Remember, what affects mom affects baby. So if mom is having an infection, now think about the first trimester. That first 8 weeks is the time of organogenesis, right? The baby's organs are forming. If she has some sort of an infection that occurs during that time, that could definitely have detrimental effects to that growing fetus, okay? In the second trimester, she may experience something we call preeclampsia. This is the most common complication of pregnancy in the United States. The most common, okay? This is a syndrome, guys. Now, do you guys know what a syndrome is? Does anybody know what a syndrome is? Who would like to volunteer?
Like a condition?
It's a little bit more than that. Diagnosed based on symptoms. Okay, you're close. Yes.
And then it goes away after that issue is resolved or completed. So like after birth, then it'll subside and go away.
Right. So it's a cluster of manifestations or symptoms. Okay. It's not just one thing, but it's a combination of things. And for preeclampsia, there is a few different things that occur in order for them to suspect that that's what they're dealing with. Okay. So obviously hypertension, because this is related to hypertension, but also protein in the urine, something we call proteinuria. Okay. That's a symptom. Epigastric pain, where they might just disregard it as being indigestion, but still could be a symptom. Headaches that don't resolve with standard treatment. Okay. So, you put all those things together and it could potentially be an indication of preeclampsia, which is a very serious condition and definitely something that requires monitoring. Generally, it gets diagnosed after 20 weeks, generally. Okay. Now, when they're pregnant, a lot of times they're going to have a lowering of their blood pressure during that first trimester and into the second trimester. Okay, because of everything growing and the hormonal influences with estrogen and all that. A lot of times we do have a physiologic lowering of the blood pressure. So maybe it's not always caught right away. And remember, blood pressure, hypertension, it's the silent killer because a lot of times you can have it and not know you have it. Okay, so there may not be even any indication to be concerned about it. All right, but when they get up to that 20-week point and beyond, now she may start showing those symptoms that we need to see. Okay. Premature rupture of membranes. Now, the way that I think of that, remember when you learned about the skin being a protective mechanism, that it provides a measure of protection against the entry of microbes and bacteria into the system. The membranes provide that same level of protection against bacteria and microbes getting into that amniotic sac to affect that fetus. But if they're ruptured, in other words, they're open now, that protection now is lost. So bacteria can get in there from the vaginal canal and can affect that baby. So generally, if mom is starting to have, let's say she's in her latter half of her second trimester, or she's into the third trimester, whatever the case may be, but she's having leaking, quote unquote, that could potentially be amniotic fluid, which could indicate that the membranes have ruptured. And if that occurs, she needs to get in and get checked right away. They need to evaluate whether or not it is actually amniotic fluid that's coming out because of that potential for infection. Okay. So premature meaning that the membranes rupture before the onset of labor. So she's not in labor, but the membranes have ruptured. Okay, so for the third trimester, we talk about some of the maternal complications, things that can affect mom, very similar to second trimester, but they also could have gestational diabetes. Okay, this a lot of times can manifest during that third trimester. Placenta previa, which we're going to talk more about in a little bit, and or placental abruption. Some of the complications to the fetus, decreased growth. Growth is very important. So we don't want the baby to be too big. We don't want the baby to be too small. Decreased movements. Remember, that's why we do the kick counts. That's why we educate her about doing kick counts. Hypoxia, because baby thrives on oxygen just like we do. And of course, infection. So those are some of the more common danger signs of pregnancy that we're going to educate our clients about. Any questions over those? Okay. All right. So this is important information, so please pay attention. There is a lot of confusion between whether or not what you're dealing with is a previa or an abruption. Okay. If they are having a placental abruption, which is what you see in the top, there is an example of an abruption. Dark red, painful bleeding. Think of an abruption as a detachment. The placenta is actually detaching from that uterine wall. It's detaching. Okay. Previa is basically the placenta has implanted in the wrong place. We expect the placenta to be up towards the top of the fundus. That's where we expect it to implant. But with a previa, it does not implant there. So if you see in the bottom picture there, where you see the little red spot that says cervix, so that's where the baby needs to come out. But sometimes with a previa, the placenta is there and blocking that exit. And that's a problem. And sometimes that can cause bleeding, bright red, but the bleeding is painless. There is no pain with a previa. That is the definitive difference between the two. Bright red and painless, that's a previa. There's different types. So the example that I have on your screen there is a marginal previa. There's also a where it just kind of halfway covers the cervical os, and then there's a complete previa where it completely covers the cervical os. If you have a complete previa, then that baby's not going to be able to be born vaginally. You're going to have a C-section in that case because there's no way for the baby to get out. Okay, does that make sense for you guys?
Yep.
Yep. Okay. All right. So again, make sure that you spend some time reviewing this information because you will need to know this. So make sure that you spend some time reviewing it because this information trips students up all the time. All right. So make sure that you take some time to review it. There's a really good video from Registered Nurse RN on placenta previa versus abruption. It's excellent. It's about 12, 13 minutes long. So I would highly advocate that you watch that. It's a really, really good video. She does a really great job of delineating the two. Okay, moving on. So I kind of touched on this earlier, the ectopic pregnancy, but we'll just talk about it now. So basically, our egg has been fertilized, but not where we want it to be. It implanted in the wrong spot. Okay, 98% of these types of pregnancies occur in the fallopian tubes. Obviously, there's not a lot of space there for the baby to grow, so that's not going to be good. That pregnancy is not going to be able to go to term, right? It's just not. Abdominal pain can be either generalized or it can be unilateral. In other words, the side of the where it will eventually rupture. That's where they feel the pain. There can be a lot of bleeding with this and a lot of pain. Okay. So if she's, in the early stages, that first trimester, this is going to occur during the first trimester, and she experiences a lot of really sharp, intense abdominal pain, and then she's having bleeding, the first thing they're going to think of is this could potentially be an ectopic pregnancy. Now, sometimes she may not even know she's pregnant yet. Some women have spotting in the first trimester because of the implantation into the decidua, and that sometimes causes bleeding. And so she may misinterpret that as being her menses when it really isn't. So she may not even really know she's pregnant yet. If she's really not having any of those other signs, those probable signs of being pregnant. But it can lead to death because of bleeding, right? She could bleed out. So she may be hypotensive. She could be tachycardic. Remember, if you have a hypotensive person who's tachycardic, always think volume. There is volume loss happening there. There is bleeding from somewhere because we're not going to have a really low blood pressure and a really high pulse. That's not going to happen if there's nothing wrong. There has to be fluid loss from somewhere. Okay. And she's probably going to say she's dizzy. So she's definitely going to be symptomatic. And this is a lot of times what you see coming into the emergency room is these types of situations. So obviously we have to confirm the pregnancy, we have to make sure. So they can do a transvaginal ultrasound to confirm pregnancy. Look for any other reason why she could potentially be having this pain and this bleeding. Fluids is going to be important. She may or may not need blood. So she may or may not need to have a surgical procedure done. If the tubes rupture, then she may need to have a surgical procedure done to fix that. Does that make sense for everybody? Any questions on the ectopic?
So don't you have to get that like taken care of? Like that's not, they take that out, right? Is it like a surgery or?
There is no way that that baby is going to be able to grow.
Right. Is that so? Do they take that out immediately?
Oh yeah.
Okay.
Yeah, they're not going to leave that.
Okay.
Nope. Good question. Good question. Any other questions, guys, before we move on? Because I got one more case study after we talk about preeclampsia.
Let's go.
Let's go. Thank you, Ron. All right, here we go. Preeclampsia, as I said, most common maternal complication in the United States. It's the most common cause of maternal death in the United States. All right. So, multi-system, lots of systems involved. The kidneys can be involved. Okay. Vasopressive disease process. It's hypertension causes that constriction of the vessels, right? That's what causes the pressure to keep going higher and higher and higher because the narrowing of the vessels, okay, and the pressure that's being applied. This is a disease of the placenta. This is what they figured out. They don't really know everything about this problem, but they do know that it is a problem of the placenta. So that's why we say that the cure for this, quote unquote, is the delivery of the baby and then the delivery of the placenta. Okay. Increase in blood pressure after that 20-week period. That's kind of the gold standard for diagnosing this problem. Accompanied by proteinuria. Again, the kidneys are affected, so when you start spilling proteins into your urine, that is an indication of a kidney problem, potential kidney failure. Not good. Edema to the face and the hands. Now, we get edema during pregnancy, but generally not to the face and the hands. Generally, the edema is going to be more dependent or to the lower extremities is where we're going to see it most often. But this is not considered indicative of preeclampsia anymore, although it is a cause for us to be on alert. If we're noticing or she's noticing that she's got edema to her face and her hands, that could be, we need to look into that. We need to do a little bit more investigation. Headaches, as I said earlier, that don't resolve with standard means. You know, if you take Tylenol for a headache and this is not getting any better with Tylenol, then that could potentially be an issue, especially if you're into your third trimester. That's definitely a concern. Changes in your vision. A lot of times they'll say they have double vision, or maybe they see halos around, okay? So it's just the pressure that is being applied that's causing issues with their vision, okay? They may have epigastric pain. That's very common with preeclampsia. Women say they have epigastric pain. Now, if it's severe, these women might end up on bed rest for the last part of their pregnancy because activity can increase the blood pressure. So we don't want to do anything to increase the blood pressure. Now, this would be a bummer because basically they are on strict bed rest with just bathroom privileges. Now, I can't think of anything worse. So a lot of times these women end up, if it's bad enough and they need frequent monitoring, these women end up being hospitalized for an extended period of time until they deliver because they need to be attached to the monitors. We need to be watching them. We're monitoring their blood pressure. We're monitoring baby, you know, monitor. So, you know, I have seen them where they've been in for weeks like the last 6-8 weeks of their pregnancy. I can't think of anything worse than that. But, you know, we want a healthy mom, we want a healthy baby. And if that's what we have to do to get it, then that's what we have to do. Okay, it's extreme. I mean, it doesn't happen, obviously, for everybody. But if her preeclampsia is significant enough, then that's what we're going to do. The concern with the preeclampsia is that it could develop into what we call eclampsia. Eclampsia. What is eclampsia? Does anybody know?
Seizures?
You got it! Yay! Good job! Thank you so much for sharing that. Yes, seizures. So a lot of times with these moms, when they're going into labor, if they have really severe preeclampsia, they're going to be started on mag sulfate because they need to try to prevent the seizures from occurring. Because if she goes into seizures, that could be life-threatening for both her and for baby. Okay, so we definitely don't want that to occur. So that's what we worry about most with preeclampsia, is that she'll become eclamptic. Okay, now once she goes on that mag sulfate, then we have to be monitoring her even closer, because now she's going to be a fall risk, because it's going to relax that smooth muscle. Okay, that's part of what it does. The other thing that it does is it provides some measure of protection for the fetus for their brain. That's what they found. Okay, does that make sense for everybody? Any questions on that?
Can you say that again? It protects the fetus from what?
Their brain. The brain, the baby's brain. It provides some measure of protection for the baby's brain. That's another reason for giving mag sulfate. Because especially if we're talking a premature, right? They're not term yet. They're not supposed to be delivering. Sometimes they may have to take that baby early because of if the preeclampsia is so bad. So the mag sulfate is going to provide some protection for baby's brain, because the problem with premature babies is those vessels in their brain are so delicate that the shock of being born can cause them to blow, can cause them to rupture, and that causes bleeds in their brain. Did that answer your question, Belinda?
It did. Thank you.
Oh, good. Okay. Any other questions, guys? Otherwise, let's go to our last case study. This should be a good one. Okay, here we go. Woo! All right. Buckle up, guys, because we're going to the store. All right. You're in line at the supermarket, and the pregnant woman in front of you suddenly doubles over, clutching her abdomen, crying out that she's having pain. Then she collapses on the floor. Biggest nightmare ever. You palpate the abdomen and find it to be very rigid, with obvious tenderness. She's, facial grimacing, like she's indicating that it's hurting when you're touching, even after a couple of minutes have passed. So you alert someone to call 911 because you know that this is not good. So what could be happening? Let's figure that out first. Think about what's going on. Put your critical thinking cap on and tell me what you think might be happening.
Possible miscarriage?
Yeah. Spontaneous abortion.
Okay.
Could she possibly be going into labor?
A contraction?
I don't think she'd go into labor that.
It's
I think if you start labor, it's not that crazy.
Oh, someone said it. I heard someone say it. Say it again.
Abruption.
There you go. Yes. Thank you. Thank you. Not that it couldn't be aborting, but she's far enough along in the pregnancy where abortion probably wouldn't be what we would be most concerned with. And what you're looking at, the red flags, as it were, is that she's clutching the abdomen, she's having such intense pain, and it's tender. Those are classic indications of abruption. Classic. All right.
Does this happens over time, or does this
is the placenta like that? Like when the woman is pregnant, or does that occur slowly along the pregnancy? How does that create in the process? Do you get what I'm saying?
Yeah, no, I understand what you're saying.
Okay.
So let's say that this particular lady, and we don't know, all we know right now is that she's on the floor, she's having a lot of pain. But let's say that she has a history of preeclampsia. That pressure, that high blood pressure, can contribute to an abruption because that pressure is being applied, it's being applied, it's being applied. And the vasoconstriction can lead to an abruption. Now, they can have a partial abruption where it's not completely detached. And sometimes the blood that we might see that would tell us, oh, it's dark red, that's telling me it's abruption. We may not see that because it could be hidden behind the placenta because the placenta is not completely detached. It's partially detached, and that can happen. So, but in this case, my concern is the pain that she's having because I wouldn't anticipate that she's going to have that kind of pain. So, you know, I would definitely be concerned about abruption. Did that answer your question, Belinda?
I kind of mean like how long can that take? Is that like an instant thing that happens if say she is
It generally happens pretty quickly.
Okay.
Yeah, it generally does happen pretty quickly.
Okay. Thank you.
Mm-hmm. Yeah, and it's definitely a concern. If they have any concern at all about abruption, they're not going to let that lie because that's only going to lead to more problems down the road. So this is an indication where they may potentially need to do an emergency C-section to take baby because once the placenta is detached, well, now the baby is losing its lifeline because the placenta supplies everything for baby. It supplies all of its nutrients. It supplies all of its oxygenation. It exchanges all the waste products. It does everything for baby, right? The baby's organs, a lot of them are inert in utero because the placenta is doing all the work. Like their lungs are basically inert when they're in utero because the placenta is doing all that for them. They don't have to do it. So babies aren't really breathing when they're in utero. They don't breathe until they are born, until they are exposed to that outside environment. Did that make sense for you guys? So if the placenta is detaching, that's a problem because that's a problem for baby. Huge, huge problem. So what can we do with this lady? Now we're in the store. Someone called 911, thank goodness, and we're waiting. Is there anything that we could do to help her? Anything?
Left lateral position.
Good. Yes, excellent. Oh, wonderful. Thank you so much. That's awesome. Thank you, Ron. Yes. Because why? Why do we want our left lateral?
Oxygen.
There you go.
Baby gets
Oxygen for baby. Excellent. Excellent. Now, we want to provide as much information as we can to the EMS when they get there. Okay. So what kind of questions do you think we want to ask her?
History. How far along are you?
Good, Shannon. Yes. How many weeks? What's the gestation? Yes. Ron, you were saying something I didn't quite catch.
History. First pregnancy. Is there a history of this in your family?
Oh, good. Yes, yes. Let's find that out. Is this her first pregnancy? Did she have this problem in the past? I mean, hopefully the EMS, I mean, you're going to be thinking, when are they going to get here? But you just have to try to keep her calm as much as you can because we don't want her to get excited. And, you know, can I call anybody for you? That would be important. Let's get her loved ones involved. Because she's there by herself. She's not with anybody. So let's, who can I call for you? Let me alert them to what's going on and either have them be on their way here or head to whatever hospital that you're going to be taken to. Now, in emergency situations, they're going to go to the closest hospital. They're not always going to go to the one maybe that her providers are at. They're just going to take her to wherever's the closest one because this is an emergency, quote unquote. So, all right. Any other questions we want to ask her? Very good, guys. This is awesome.
Any known complications with the pregnancy or any relevant, like pertinent medical history?
Okay, good. Yep. Yeah. Has she been having any issues? Good.
Level of prenatal care. When was her
Oh, wonderful. Thank you, Belinda. Yes. Have you been having prenatal care? So a lot of times you may come across someone who has not had either adequate prenatal care or any prenatal care. It's more common than you might think. And there's lots of different reasons for why women don't have prenatal care. But it definitely would be something that we would want to know so that we could relay that to the EMS because they're going to have to relay that to the hospital when they get to the hospital. Does that make sense for everybody?
Yep.
Okay. Awesome, guys. Well, good. I hope this never happens to you. If you're in line and there's a very pregnant woman ahead of you, you know. Oh, I can say I'm going to knock on some wood because you watch. The minute I go to Target or something, it's going to happen to me. It has not happened to me yet. I had someone pass out on me at the health club, but they weren't pregnant. It was because their blood sugar bottomed out, and that was bad enough. Oh, awesome. Good job, guys. Thank you so much for going along with these discussions. I thought we had a great discussion today. Everybody seemed very engaged, so thank you so much. That's all I have for you guys today. Does anybody have any final questions before we end for today?
I have about the ATIs for this week.
Okay.
So is the only thing we're turning into you like our progress, the test at the end? Because all the other ones, there's no tests. We just go through it.
You're just turning in the score for that test. The maternal. Okay. Yep.
Okay,
That's it.
I just was like, is there anything else? I can't find it. Okay.
Nope.
Yeah, I was confused too because when you look at the calendar, there's a whole list of things we're supposed to be, but there's only one drop box for the one test.
Right, because there is only that one test at the very end. You go through the tabs, but there's only the one test at the end. I think it's like 10 questions. That's it.
Yeah.
Yep.
Okay, I thought I was behind the 8 ball. It's like, I didn't do those.
No, you're right. You got it.
Okay. All right. And now for this week, there are or there are not ATIs?
Just that one. Just that one that you guys were just asking me about. That's the only ATI for this week.
Okay.
Yeah, I know that there's some listed in the module, but those are not the ones that you're doing. You're doing the ones that are in the calendar.
It's confusing.
I know, but I can't adjust that. There's no way for me to take that out. So sorry about that. I do apologize.
I just wish we had like a list of each week what was due.
Well, that's why I put it on the calendar.
I know, but that's getting a little confusing. It is confusing there. I don't know. Okay.
Okay. Any other questions, guys?
Nope. Thank you.
You're very welcome. You guys have a great day. Those of you that have me in clinical, I'll see you guys at 12 o'clock.
Alrighty.
Bye.
Bye. Thank you.
You're welcome. Thanks for coming today, guys. I appreciate it.